Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Corcept Therapeutics. This activity includes discussion of therapeutic products that have not been approved by the U.S. Food and Drug Administration, off-label uses of approved products, or data that were presented in abstract form. These data should be considered preliminary until published in a peer-reviewed journal. Readers should verify all information and data before treating patients or employing any therapies described in this or any educational activity. A qualified healthcare professional should be consulted before using any therapeutic product discussed herein.
Hello, I'm Richard Aucus, Professor of Pharmacology and Internal Medicine in the Division of Metabolism, Endocrinology, and Diabetes at the University of Michigan in Ann Arbor. Welcome to this program titled Celebrating Advances and Addressing Inadequacies in Hypercortisolism Management in the Modern Era. I'm delighted to be joined by my colleagues, Oksana Hamidi, who is Associate Professor in the Division of Endocrinology and Metabolism at the University of Texas Southwestern Medical Center in Dallas, and Dr. Honey East, who is graciously joining us virtually for this discussion. She is an endocrinologist and director at Metabolic Medicine of Mississippi in Jackson. Welcome, Honey. Oksana and I are at Endo 2025, the annual Endocrine Society Conference in San Francisco, California, the city by the bay. This is where I did my postdoc before becoming a faculty. So today we're going to talk about why cortisol matters in type 2 diabetes and hypertension. I think we all recognize that classic hypercortisolism, Cushing disease, Cushing syndrome, causes hypertension, diabetes, and osteoporosis. So then as we start to peel back the envelope further and look at the early stages of disease, we wonder now what is the prevalence of hidden hypercortisolism in these rather common conditions. And it can be, they can affect between 0.2 and 2% of the population. So in total, it's about 10% of the general population. So, and we know that diabetes, hypertension, fractures lead to cardiovascular events and mortality. So we are today going to pursue the issue of whether patients with hidden hypercortisolism have hypercortisolism as a cause of some of these underlying conditions, and if normalization of this cortisol activity can result in a reduction of fracture risk and if improved glycemic control. So before we move on, let's take a look at this video of Karen as she describes the struggles that she endured before she received a proper diagnosis.
Hypertension became a problem and type 2 diabetes became a problem. I was diagnosed with both of them around the same time. I was getting pretty high levels, very scary at the time. They were levels that my doctors would say, you know, we've got to get this under control because you're going to end up stroking out. That was very scary feedback to hear. They were piling on the medications. Medication after medication. Let's switch your medication. Let's send you to another specialist. Maybe this person can figure it out. It got to a point where doctors were blatantly blaming me for my demise.
It definitely was frustrating. You find yourself, me not having the illness, but you're there, you're waiting with the person and you're living with them and you're supporting them. You find yourself in a never-ending fight a struggle. You're always constantly fighting. And, it developed in me a large, maybe I'm not the most trusting person to begin with, but a skepticism towards the medical industry.
I think the scariest time was when I had a blood pressure reading of like 210 over 100, and I was convinced that I was dying. A1C, the highest A1C that I've had is 12.4. So these were numbers that you hear about people having their toes amputated for, or people having strokes. I was watching TV late at night, and I came upon a television show that talked about people with rare illnesses and the steps they took to get diagnosed. At the time, I was pregnant with my 14-year-old daughter, and I was about 4 weeks away from having a scheduled C-section. But I started checking off all the boxes of my illness, and there I had my answer. It was Cushing's syndrome. I made an appointment with the endocrinologist who had actually misdiagnosed me prior to then, and I told him I want to be tested for Cushing's. He looked at me and told me there was no possible way that I could have Cushing's. Some of the reasons were women with Cushing's do not have children. You have 2 healthy children at home. Your stretch marks are not purple enough. You probably have not done enough to lose the weight. And it's way too rare. We're taught that we'll probably never see a case of it. There's no way you have it. I said, I am not leaving your office. I saw this episode on this TV show. I am not leaving your office until you start testing me. So he started doing some of the testing, and to his surprise, I was showing up positive for some of the markers for Cushing's syndrome.
You know what? I felt like we could support my wife best by being there for her, because we all were going through it together, and no doubt about it, we became closer as a family.
When I finally was told that, yes, you have this disease, it's so ironic, but I felt joy, I felt relief, but I also felt very scared. By that time, my functioning had decreased significantly. I had to abruptly leave private practice. Things were pretty bad. What the diagnosis ultimately gives me is a sense that I have control over my life and that I can do something about it, even if my symptoms are not 100% eliminated. I know that I wake up every day and I can do something about what's happening because I ultimately do have a sense of control.
So, what can we learn from her story? Let's start with you, honey.
Oh boy. I mean, you can hear the frustration at the whole process, and the lack of diagnosis, the lack of any provider being able to figure out the underlying cause of her problem. And then you can hear the relief in her voice, when she was finally validated, that there was a cause behind all of these symptoms that she was having. And I think this is something that all 3 of us see on a regular basis, because, these patients have been blamed and shamed by physicians. They've been told your diabetes is not controlled because you're not eating right, because you're doing the wrong things, or your blood pressure is very resistant. Are you really taking your medications? And so as a result, these patients are really frustrated, and they don't reach the control that they need. These patients don't respond to the usual drugs because of their underlying hypercortisolism many times. So it's something, in practice, your patients don't want to have hypercortisolism. But if they do, they really do want to be diagnosed because they really do want to be helped.
Yeah, I think there's a paradox there that even though we have very good drugs for treating diabetes and hypertension, that the dismissal of the treatment resistance as being the patient's fault rather than being due to a secondary cause of a relatively common disease is a very distressing issue.
I think yeah, no, and again, I think when we all trained, we were told that Cushing's was so rare that we may never see one. And with the data that you just talked about and that we'll talk about later, we now know that it's really much more prevalent than we would have ever dreamed. But as a result, I think providers and physicians have been reluctant to even think of the diagnosis, let alone make it.
Right. Yes. Unfortunately, there are many patients like Karen. And Dr. Hamidi, I want to ask you about in your practice, what is the phenotype of patients that you see that have gone through this same process?
Yeah, and I think unfortunately the big problem is that as we are going through medical schools, we are taught that Cushing syndrome is something that is extremely rare, and most likely in our career we will hardly see it, if ever see it again. So in my practice, many patients who come to see me, they express this, that I talked to my doctor, brought this up, and they said, well, it's so rare, it's very unlikely, and I've been told that it's very difficult to diagnose and it's unlikely that this is what's going on. Think another difficulty is that high blood pressure, diabetes, and other complications like weight gain, obesity are very, very prevalent in a general population. So that for providers, it also makes it more difficult for us to find those patients, to have a level of suspicion in order to proceed with further testing.
Right. Okay. So when we think about Cushing syndrome, one of the characteristics of it is that it has protein manifestations, that it influences multiple organ systems. Because there isn't really a cell in the body that doesn't have glucocorticoid receptors. And so we think about central nervous system effects, depression, anxiety, poor sleep, worsening of hypertension, inability of hypertension to respond to common medications, worsening of diabetes, someone who's been well controlled on one or two medicines that all of a sudden loses the ability to maintain their A1C, and then unexplained fragility fractures, especially people who have obesity and diabetes and hypertension usually don't get fractures. So if you see fractures in somebody who's overweight, then you have to wonder that there's some reason for this beyond the typical age-related bone loss. So I think we also are aware now that there's also lurking in the background this issue of non-neoplastic hypercortisolism. So we talk about neoplastic hypercortisolism due to tumors of the pituitary, ectopic ACTH syndrome, adrenal tumors, which would be ACTH-independent disease. But then there's other situations where hypercortisolism is a physiologic response to pregnancy, psychiatric illness, alcohol abuse, pain, acute medical illness, exercise, and other stressors on the body. But then after a while, if there's this illness becomes chronic, then there can be a maladaptive continuous hypercortisolism. And what impact does that have on these underlying disease? So how do we go about testing for hypercortisolism? What do we know from the CATALYST study, and where are we now?
I think back to your issue that you brought up about non-neoplastic hypercortisolism, or as we used to call it, pseudo-Cushing in the past, which I still sometimes people refer to it that way. The difficulty with that is that figuring out, is it the underlying medical condition like uncontrolled diabetes or uncontrolled depression causing elevated cortisol, or is it cortisol causing this issue? So what's the chicken or the egg difficulty? Another aspect that complicates this situation is that the testing for hypercortisolism and both pseudo-Cushing can look very, very similar. Patients can have abnormal dexamethasone suppression test, late night salivary cortisol, even 24-hour urine cortisol. So again, teasing out those two apart could be a challenge. And it's important to make that distinction because before we start treating the patients, I think we need to know what's the underlying etiology. Then I would say, though, with neoplastic hypercortisolism, typically those levels can be significantly elevated, as opposed to with pseudo-Cushing or non-neoplastic, they tend to have rather milder elevation in these biochemical tests. As we know, the 3 screening tests for Cushing would include overnight 1 milligram dexamethasone suppression test, a 24-hour urine-free cortisol, which is usually done in at least 2 measurements, as well as midnight salivary cortisol, which is done at patient's natural bedtime, also at least 2 samples for that. And then once biochemical hypercortisolism is confirmed, this is when we would proceed with subtype testing, which includes measuring ACTH. So then we measure ACTH level, and it's typically done in the morning around 8 a.m. If ACTH level is elevated, or we call it non-suppressed, this would be consistent with ACTH-dependent hypercortisolism, which could be the source for this either pituitary adenoma, Cushing disease, or at times ectopic ACTH secretion or ectopic Cushing syndrome. And this would lead us to pursue MRI imaging and sometimes additional testing like petrosal sinus sampling, or at times even high-dose dexamethasone suppression test. And then on the other hand, if ACTH level is suppressed, this would signify ACTH independent process, which would typically make us look at the adrenal gland, whether it's CT or MRI.
All right, yeah, so the 3 principles of testing: cortisol production is high, that's the 24-hour urinary free cortisol. Circadian rhythm is blunted, that's why you do midnight salivary cortisol. Cortisol cannot be suppressed, that's why you do an overnight dexamethasone suppressed. Different reasons for doing different types of testing. So in the CATALYST study, about 1,000 patients underwent a 1 milligram overnight dexamethasone suppression test, and the primary endpoint of the study was to determine the prevalence of hypercortisolism defined by the 1 milligram overnight dex suppression test, failure to suppress cortisol to less than 1.8 micrograms per deciliter. And this study excluded people who have common reasons for falsely elevated cortisol, such as birth control pills, uncontrolled psychiatric illness, and so on. And then they underwent further evaluation to determine if there was ACTH dependent or independent. Some patients then went on to have the full evaluation, as you're describing, for pursuit of a surgical cause. And these patients, who all had difficult to control type 2 diabetes, defined by an A1C between 7.5 and 11.5%, despite taking 3 or more drugs or some other combinations of hypertension and diabetes and complications from these. So these are people who are not doing well, who are receiving pretty good therapy already. What did they find? They found that a quarter of these people, 24%, failed that overnight dexamethasone suppression test. And if they were taking 3 or more antihypertensive drugs, meaning they had resistant hypertension and resistant diabetes, it was over a third of them, 35%. So that was part A. But maybe, Oksana, you can start us on the second phase, the treatment phase of this study.
So indeed, those were very interesting findings. Perhaps some people can consider this surprising, but if you're looking at the incomers, these were a high-risk population, meaning that the pretest probability was already quite high. So in a way, this is not surprising to see such a high prevalence of abnormal dexamethasone suppression test. Again, all of these patients had uncontrolled or treatment-resistant, difficult to control diabetes. And then those patients who tested positive with dexamethasone suppression test and did not have elevated ACTH proceeded with potentially being enrolled in part 2. And the study included 2 arms. In the first arm, patients were treated with mifepristone, and then the second arm was placebo. And those patients were randomized 2-to-1 ratio into each arm. The treatment took place for 24 weeks, and after that, the patients underwent a follow-up period. And primary endpoint was to look at the change in hemoglobin A1C from baseline to week 24 in both arms.
So, Honey, what did this study find, and as a result, and did this surprise you?
So the results absolutely surprised me. By week 12, we saw a significant reduction in A1C in the treatment arm versus the placebo group, and we saw continued improvement by week 24 in the group. And again, this is in a patient population with hypercortisolism who really has not been officially diagnosed with a more traditional form of what we think of Cushing's disease or Cushing's syndrome.
Yeah. So, and I think the other surprising finding from the study is that despite a 1.3% placebo-adjusted reduction in hemoglobin A1C by 24 weeks, the people who were taking mifepristone, about half of them stopped their long-acting insulin, 30% of them stopped or reduced their short-acting insulin, and came off other medications, including tirzepatide, during the course of this treatment, whereas very few of the placebo patients reduced their medication burden. And so there was a reduction in body weight, a reduction in BMI and waist circumference, reduction in glucose-lowering medicines. Now, the one thing, the safety events and the dropouts, were those similar to what we see when we treated patients in the seismic study with Cushing disease for mifepristone?
So the adverse events were comparable to the known safety profile of mifepristone. Those adverse events that occurred in 10% or more included some signs and symptoms that we see with cortisol withdrawal symptoms, such as fatigue, nausea, vomiting, headache, dizziness, as well as potential effects of mineralocorticoid activation, such as hypokalemia and peripheral edema. Also, we did see some increase in blood pressure in some patients.
Right. So, okay, so now we're in this post-catalyst era, if you will. Oksana, I want to start with you. Where could clinicians be doing better in caring for their patients?
I think the main thing is for clinicians and even patients to know that we have to have a lower threshold for testing, especially that we know this data showing that the prevalence of abnormal DST is quite high, a quarter, in these patients with uncontrolled or difficult to control diabetes. So I would say that we know that risks like having chronic obesity actually have low pretest probability, but this is definitely a population that is enriched with potentially this abnormality. So I would urge everyone to be more on having a low threshold for testing.
Right. So it's not just obesity, it's obesity with cardiometabolic manifestations such as poorly controlled diabetes, resistant hypertension. That should raise an index of suspicion. And I think the interesting thing, you mentioned non-neoplastic hypercortisolism before. We don't know how many of these patients had neoplastic, how many had non-neoplastic hypercortisolism, but they all responded to mifepristone. So whether it's the chicken or the egg, it's contributing to this process in some way. And there's still a lot of science that we need to do to sort out what's going on and how to best manage these patients.
Indeed, the study was not designed to really show causality.
Right.
We can see an association.
Right. Okay. So this was done with mifepristone. It's a very good drug for controlling glucose, and its label indication is for treating hyperglycemia with hypercortisolism. But what are the other drugs that are development now that might be useful in this condition? Dr. East, do you have any comments on that?
Well, relacorilant is under investigation right now, and it is a selective glucocorticoid receptor antagonist. So, mifepristone, as we know, also affects the progesterone receptor, and we can see other potential side effects, particularly as related to possible endometrial hyperplasia and the abortifacient effect. What the newer generation will do is it will take that receptor activity off the table, if you will, and is just a selective glucocorticoid receptor antagonist.
Right, and I'm also aware of atumelnant, which is an ACTH receptor antagonist, and then the LUAG 13909 ACTH antibody. Those would be effective in ACTH-dependent disease and not an ACTH-independent disease. Let's take a step back and let's think about these people like Karen who first suggests the evaluation for Cushing's disease. Well, there was a survey of 269 patients in collaboration with the Cushing Support and Research Foundation, the CSRF, and they found that 76% of the time it was the physician, but 11% of the time it was the patient itself, like Karen in the video. 9% of the time a friend and family, APP or dietitian or nurse or somebody else with Cushing syndrome. So about 25% of the time it's not even the doctor that suggests the searching for this diagnosis. And so we went over a couple of options, but we should review everything. So Oksana, why don't you go through all the drugs that we have for treating hypercortisolism, when they're useful, what are their limitations?
So thankfully, compared to when I was going through med school, now we have many other options to treat the Cushing syndrome. There are 3 classes of medications that we can use to treat Cushing syndrome depending on etiology. So first class would be pituitary-directed agents, and those would include cabergoline and pasireotide. Pasireotide is the only FDA-approved therapy for Cushing in this category. We're looking down at glucocorticoid receptor antagonists, which include mifepristone and, as we touched on, relacorilant, which is currently under investigation. And then adrenal-directed agents would include ketoconazole, levoketoconazole, metirapone, mitotane, etomidate, and osilodrostat. And of course, these are not specific for Cushing syndrome, but oftentimes we use mineralocorticoid receptor-driven hypertension. We would use mineralocorticoid receptor antagonists such as spironolactone, eplerenone, or at times amiloride.
Right, because cortisol can also activate the mineralocorticoid receptor under certain circumstances. Okay, so let's just step back again and try to summarize things. The impact of hypercortisolism in difficult to control type 2 diabetes and hypertension, the importance of addressing underlying hypercortisolism, either primary or secondary in type 2 diabetes and hypertension outcomes, improving patient outcomes and quality of life. As you know, both of you know that if you diagnose somebody with Cushing's, find a tumor, and are able to cure them, you've made an enormous impact on their life. But we shouldn't stop there. And the strategies for identifying and managing Cushing syndrome in people with difficult to control type 2 diabetes and hypertension. So honey, do you have any further comments?
Yeah, I can't stress how helpful it has been, particularly in my practice, to now have medication options, particularly for the more subtle cases, or the less severe hypercortisolism cases. And because we may not be able to find a source while surgery is still the gold standard. It's not always an option for patients. And then on the flip side of that is, patients with hypercortisolism are sick. And many of them have uncontrolled diabetes, or they have uncontrolled heart disease, or they have some other contraindication for surgical intervention. And it is such a fantastic time right now to be treating patients for hypercortisolism, because we do now have good medical options as well.
Right. So yes, so still a lot to learn, but at least now we have a few more tools in our toolkit that we can use to address the problem. So if you want to learn more, you can visit this educational curriculum called Clinical Advances in Hypercortisolism in Difficult to Control Cardiometabolic Conditions. And so Oksana and Honey, thank you so much for this great discussion today, and thank you for participating in this activity. So please continue on to answer the questions that follow and complete the evaluation.